Our first speaker, Dr. Brent Townsend. He's one of 3 new pediatric radiologists who have joined Wake Radiology this year. He's a native of Trinidad and is magna cum laude graduate of Harvard University. He received his medical degree from Duke and conducted research at the Duke's Brain Imaging and Analysis Center in Durham. He completed an internship at Moses Cone Memorial Hospital in Greensboro. Dr. Townsend then moved to Boston and did his radiology residency training at Brigham and Women's Hospital, followed by a fellowship in pediatric radiology at the Children's Hospital. He's authored several articles in journals of computed assisted tomography, ultrasound, Journal of Ultrasound Medicine, Journal of Neuropsychiatry, and Clinical Neuroscience. When he's not working, he enjoys running, cooking, and tennis. And he's noted for his astonishing bravery because while he's here lecturing, his wife is at home with their small child and she's ready to have a baby at any moment. So he's the only one allowed to have his cell phone on. Okay? So please welcome Dr. Townsend. He discusses the child with a UTI.
Thank you very much. That's probably the highlight of this talk, is that introduction. Thank you. So you guys have heard a lot of high-tech imaging, etc., and I think Dr. Margaret Douglas and I are now going to cover what's called the pee and poop section, my wife said when she was looking at the itinerary. I'm going to talk about the child with a UTI and how imaging can help with that particular clinical problem. I'm not sure what percentage of you guys are pediatrics, family practice, see a lot of kids? Yeah? A good deal? Okay, well, if anyone has any questions at any time, just interrupt me and we'll move on from there. So why worry about a UTI? Well, it's a pretty common disease process. They estimate 3% of school-age girls will experience one and less than 1% of school-age boys, but there are a lot of school-age boys out there, so that's still a lot of patients. And then, other than the patient's discomfort and time away from school, parents' stress and anxiety, people have started thinking more long-term, what if the UTI becomes pyelonephritis, an infection of the kidneys rather than just an infection of the bladder? And then thinking even longer term, 40, 50 years, what role does pyelonephritis play with scarring of the kidneys, losing renal parenchyma, which may then lead the patient to have hypertension or chronic renal disease in later life? So we're really thinking both at the kid at time of imaging and we're looking 40, 50 years down the road when we're talking about a child with a UTI. So what is the role of imaging in a UTI? It's a very common clinical diagnosis, and also catheterized specimens in your offices can come to the diagnosis. But imaging can help distinguish between pyelonephritis and just a lower UTI. And if the patient does have pyelonephritis, imaging can help you assess for complications of that. And additionally, imaging can be useful for the diagnosis of reflux, where urine heads up the ureters back towards the kidneys instead of down the normal one-way street, and monitor the treatment of reflux, as well as allow for the identification and evaluation of anatomic abnormalities in the kidney that a patient might have. And furthermore, imaging can be used to evaluate renal function. So what are some of the modalities at our disposal? I know you guys heard a lot about CT and MR. I won't talk too much about the physics of all these modalities, but know that ultrasound is really the workhorse of pediatric imaging. It's 1, no ionizing radiation. 2, it's relatively cheap. And 3, it's actually quick, and most places have an ultrasound machine. It's a lot of access for a lot of patients. Fluoroscopy, which is essentially using real-time x-rays while the patient is on a table, is another way that we can help image UTI, look for reflux, but that does involve radiation. The number that I'm going to quote here is about a standard VCUG, avoiding cystourethrogram, which I can explain more about later, will have about 16 times the radiation of a single frontal chest x-ray. Now, there are various nuclear medicine imaging things we can do, including a radionuclide cystogram, which is essentially like a VCUG, but with nuclear medicine and nuclear cameras rather than X-rays, and I'll explain the difference between the two a little bit later. DMSA scintigraphy, which is a scan that we give a radiotracer that is taken up by the nephrons in the kidneys, and thereby we can see where the kidney has scarring or where there's a lack of nephrons or blood is not getting to the kidney. And then the MAG3 study, a renogram. MAG3 is a radiotracer that's taken up and excreted by the renal tubules. So instead of a cortical evaluation, it's more of a tubular and functional evaluation. The numbers in the literature say that any one of those nuclear medicine studies have about 9 times the radiation of a standard chest X-ray. And then lastly, CT and MRI, which you heard a lot about earlier. A standard abdominal CT has 250 times the radiation of a chest X-ray. Not typically used in the evaluation of UTI or its complications, but I'll explain where it comes into it. An MRI, though it does not have radiation, does have, especially in the pediatric population, the need for sedation very often. The kids need to stay still for us to get all those signals from those excited photons. And so if the kid is not, probably about 7, 8 years old, kids can get it, and they can stay still. It depends on the maturity of the kid, how much of a calming influence the parents can be. Otherwise, you may need to do sedation, and that has its own risks. As well as MRI just doesn't have the same accessibility as a CT scan. Not everywhere has an MRI. And lastly, it's much more expensive. So your clinical question is, this child has a UTI, but could it be pyelonephritis? So you call me up and say, could it be pyelonephritis? And I say, well, I don't know. How can I help you out? And so what does pyelonephritis look like on ultrasound? Essentially, what you see, the pathophysiology of pyelonephritis, infection within the kidney itself. So think about it. You have this kidney, and then there's this big focus of edema and pus and inflammation. So the blood can't get to that area of the kidney. It's as though you have a sponge that's already wet or has already been made hard with something else. And so you have a focal area of hypoperfusion. Then because of the swelling, you have blurring of the very fine distinction between the cortex and the medulla in the kidney. And don't worry, I will show you pictures of it. I'm not just going to make you use your imagination the whole talk. I do have pictures in here somewhere. And increased resistance to blood flow within the kidney. So this is a case here of right-sided pyelonephritis. Let's look at the normal left kidney first. Kidney shape, sinus fat. This is the cortex. These are the medullary pyramids where the urine collects before draining into the pelvis and then heading down out into the bladder. This is what I call good corticomedullary differentiation, where you can see the cortex well, you can see the medullary pyramids. Contrast that to this kidney on the right, this wedge-shaped echogenic area compared to the normal, what we call hypoechoic normal cortex. Additionally, here you see good corticomedullary differentiation. There's nothing going on here. This is all inflamed. All the echoes, all the sound waves you're sending down are bouncing right back at us and giving us just this big mess. And so those are kind of what pyelonephritis would look like on ultrasound. Then you have the same more focal wedge-shaped defect. Another thing we can use is Doppler evaluation. Ultrasound with Doppler evaluates the blood flow. It basically looks at the red blood cells as they're moving. And here, there's just no movement. All the rest of the kidney is showing good blood flow, and this focal wedge-shaped defect is not. This is pyelonephritis until proven otherwise. And when you see this, you worry, okay, so it's inflamed, the fibroblasts are going to head down, is this area going to scar down? Has this kid lost this piece of parenchyma forever? And that's something we'll figure out. Now, ultrasound really is only about 25% sensitive for finding acute pyelonephritis. A DMSA scan, nuclear scintigraphy, is about 90% sensitive. Essentially, focal defects would look very much the same as they did in the ultrasound because the blood flow can't get there, so the radiotracer we give in the IV can't get there. So when we turn on the cameras, the isotope is not giving us any signal from that portion of the kidney. So let's say, and I'll show you another example, we have a kid with a DMSA and it shows a defect. If you tell me the kid is febrile, has right flank pain, I'll say, well, this could be pyelonephritis. If you come back in a year and the defect is still there, I'll say, well, maybe that's an area of scarring, that the blood, there's just no cortex there for it to get to at all. So that way, the clinical history really means as much to us as the imaging pictures, because to tell between pyelonephritis and what is actually scarred, I need to know how the kid is doing. And this is an example of right-sided pyelonephritis. So the radiotracer has been injected into the patient. It's being taken up by the kidney, and the left kidney is taking it up and giving us all this great signal back. And the right kidney is just looks kind of dull, washed out, because really not that much radiotracer is getting into this kidney. Now this is another view. This is left kidney, this is right. Here's that same wedge-shaped defect we're getting used to seeing around here. Basically, the tracer can't get in there. Can it not get in there because there's no cortex there? Or can it not get in there because there's pus there? Again, I don't know until you tell me what the clinical story is. And then another great thing about DMSA is that we can give you relative percent counts for each of the kidneys, because basically the camera says this many counts are coming from the right-sided kidney, this much activity is coming from the left kidney, and then you can compare it, and that way you know, okay, the right kidney is carrying 57% of this patient's load. This is important later down the road when you're starting to think, okay, I have a kidney that looks small, looks scarred, it has maybe 5% of the function of the whole renal function of this patient. If you had to, you could take that kidney out. So CT scan, very sensitive for pyelonephritis, but again, because of the radiation burden, because we have these other methods of diagnosing, it's rare that someone would send us a CT to look for pyelonephritis. More often than not, pyelonephritis is seen incidentally when the CT is ordered for another reason. Child comes in with right lower quadrant pain and fever, we're looking for appendicitis, but maybe it was pyelonephritis instead, and we see the same wedge-shaped defects, and I will show you, that you would see with ultrasound. The great thing about CT is that it does allow for the exclusion or diagnosis of alternate diagnoses. You just have diffuse abdominal pain and fever. I don't know what it is. Is it inflammatory bowel disease? Is it appendicitis? Is it pyelonephritis? And then CT can kind of rule in, rule out those different things. MRI, as I mentioned, does not have the radiation of the CT, but it does have the sedation risk. So here on CT, wedge-shaped, what we'd call hypodensity. We've given contrast to this patient. Same principle as the radiotracer. Contrast is coming down the aorta, heading into the right renal artery, filling up this whole kidney. It's coming down the aorta, heading into the left renal artery, trying to fill up this kidney, but just can't get into these areas of pyelonephritis. And then with CT, we can also do these coronal reformats that allow kind of visualization of the whole kidney at once. And you see this multifocal pyelonephritis in this patient. Okay, so the child has a UTI. You give the child antibiotics. Child has pyelonephritis. You give the child antibiotics, and they're not getting better. Well, one concern is, does the child have an abscess? Is there a focus of pus that needs to be drained in order for them to get better? And again, CT and ultrasound can be used for this. Now, let me show you. This is basically a transverse image of the kidney, and we see a wedge-shaped echogenic area. You guys are going to think this is all I do all the time. And then here, a more focal circle of what we call hypoechoic. Sound waves are coming through and nothing is bouncing back because this is fluid, which means this is pus, which means this is an abscess in this wedge-shaped area of pyelonephritis. On CT, it's the same thing. Contrast is coming in and there's just nothing here. This is the low Hounsfield units of water, so this is pus, this is an abscess. And if you see this, well, depending on the size, depending on the clinical situation, either CT or ultrasound could be used for drainage by, say, one of the interventional radiologists of this abscess if that is what's needed for the patient to get better. Okay, so I have a child with a UTI, and now you want to know if they have reflux. This is a moving target, so I could create these slides, and then I think someone would change what the actual indications for looking for reflux are. So basically, that's why I said it's going to change any minute now. I've met a lot of the pediatricians in the community since I've joined the group, and I understand that the AAP, American Academy of Pediatrics, is going to come out with a new white paper, a new set of recommendations soon. I'm not sure when, and I'm not sure how it will relate to the pediatric urologist's paper, and I'm not sure how it will relate to any other papers that are out there, AAFP, etc. Basically, my take is, if you're worried about reflux and you need me to evaluate it, I will help you evaluate it the best way possible. where I trained, Children's Hospital Boston, there were really only 3 great indications for a catheterized examination. A documented febrile UTI, and that's from a catheterized specimen, not a bag specimen, because those are so prone to being contaminated. And an abnormal ultrasound, where you see dilated collecting system, you think, oh, this kid might be refluxing, let's evaluate for reflux. Or in a patient who has a sibling or a family or a parent with known reflux. Essentially, it's about 50% coming from the parents, about 30% if you have a sibling with reflux that you would have reflux as well. And again, the goal for evaluating for reflux and possibly leading to treatment of reflux, either prophylactic antibiotics or surgery, is to prevent the scarring. Constant reflux increases the risk of pyelonephritis, increases the inflammation in the kidney, and may lead to scarring. By the way, so everything in the sheet is kind of like the cheat sheet in your folder, so you don't really need to take too many notes. And this is what we're trying to prevent. This is actually an older patient. And look at this kidney. This is right compared to the left. All these areas of cortical scarring. This is parenchyma that's not coming back. This is GFR that this patient doesn't have. This is kidney that cannot help prevent hypertension. So RNC versus VCUG. And so just to basically let me go through both of them, and then if there are any questions, please just stop me. A VCUG, the voiding cystourethrogram, has great resolution. Essentially, X-rays are kind of the best picture we can get of the body in terms of resolution, and a VCUG uses X-rays. So we can see if there is reflux and contrast goes back up into the kidneys, we can see the ureters, we can see their insertions, we can see in the kidney itself if there's actually reflux into the parenchyma, not just into the collecting system, but going into the parenchyma, which may increase the risk of scarring. And we can see the urethra during voiding, which is particularly important in boys who may have posterior urethral valves, may have a stricture, etc., that may be leading to obstruction and leading to complications. The cons, compared to RNC, VCUG has about twice the radiation. So VCUG, I'm saying about 16 times that of an X-ray. RNC, I'm saying about 9 times that. Of course, this depends on the test, who's doing the test. You know, if there's no reflux and I only need to do so many pushes of the pedal, I may not even really need to take a real X-ray. We have a thing called fluorostore, where you can just look at the patient, and whatever you see, just store it in the computer right there. You don't take a full exposure, and that can reduce radiation. But these are just rough guides I want to give you. And then the big problem with VCUGs, basically, especially in a potty-trained child, to conclude the exam, you have to get the patient to urinate on the table. Because when you urinate, the bladder contracts, that increases pressure, and about 30% of reflux only occurs during the pressure of urination. And so that's a very important image for us to get. And so it's very, very hard. And sometimes you have to wait there a long time, and you're filling up the patient, and the patient's screaming. And well, that's what I deal with. You know, you don't have to do it. Just send them for the test. I'll take care of it. So VCUG, that's one thing you have to worry about. And in VCUG, we grade reflux on a system of 5. If you just see the bladder's down here. If contrast just goes up here, 1, just to the collecting system blunting, big blunting and tortuosity, big tortuosity, big blunting. Is there really a big difference between 4 and 5? No, but is there a difference between 4 and 2? Yes, and that is what that's what you'll see in my report back to you. That's what the urologist will get, and then that can help guide treatment. Here's an example of grade 2 reflux. We have the bladder, a little wisp of contrast, and if this is all you see, this is grade 1. But then we look up at the kidneys, and there's contrast within the collecting system outlining the kidney, so this is grade 2. This is bilateral grade 3 reflux, bigger ureters, more blunting. Now, this is an ultrasound performed on a patient who actually is going to have grade 4 reflux. Sorry that I gave it away. Notice that this kidney actually looks quite normal. This one shows mild pelvic atelectasis, dilated system. So in this patient, you're suspecting something, and you see grade 4 bilateral reflux. This patient also has an extra surprise. Duplicated ureters heading into a duplex collecting system up here. And so you're saying, well, now this is just really getting kind of complicated. Does the patient actually have 2 ureters heading into the bladder? Are there 2 orifices that could be refluxing? And the great thing about VCUG is the patient's right there, you roll them on the table, you get to see the insertions. I mean, look at the detail right here. I can tell you now that there are two ureters. They become a single collecting system, and then there's a normal insertion. This one, normal insertion. In a certain percentage of patients, you're going to have what's called an ectopic insertion. Maybe that ureter is coming down and inserting below the sphincter, and this is a patient who's incontinent, and that's just the type of detail that a VCUG can give you, which we're going to contrast to a RNC, and you'll see there's just not that detail. This is grade 5 reflux, very, very dilated collecting system, marked tortuosity. For those of you who may have had such a patient, this patient has an extra surprise at the end of posterior urethral valves, leading to dilation, extra dilation, definitely not helping the pressure within the kidneys, and the pressure within the bladder, likely contributing to the reflux. Now, the radionuclide cystogram, in my discussions with a lot of the pediatricians, this test isn't as well known as the VCUG. Basically, it starts the same way. The kid gets a catheter either way. That's in the cheat sheet. So you can't tell the parents that the kid is not going to have a catheter during the procedure. Okay, so picture this. There's contrast, because we have to be able to tell what the urine looks like inside the bladder. So with a VCUG, we put in the iodine, the water-soluble iodine, and then I use X-rays to see where that iodine is. Now, the iodine itself doesn't have any radiation. The X-rays have radiation, and they are used to get the image. Now, with a radionuclide cystogram, we put in a radiotracer. It's technetium-99m labeled, sulfur colloid, and a little bit of saline. Well, a little bit of sulfur colloid and a lot of saline, actually. And you put that in the bladder, and now that has the radiation. That's the thing that's always sending out the signals. So what we do is then we turn on the camera, and we're constantly imaging the signals coming back from the bladder. So an RNC gives you continuous imaging of the bladder, the ureters, and the kidney, whereas with the VCUG, I can only see the bladders, kidney, and ureter when I press that fluoro pedal and turn on the X-ray. So that's one advantage of the RNC, is continuous imaging, because reflux is an intermittent phenomenon. If it doesn't happen when I do the VCUG, I don't see it. I'd say no reflux. Is the kid refluxing some other time? Possibly. Not likely, but possibly. And whereas the RNC is continuous imaging, and it's easier to pick up that intermittent reflux. But the cons, because of again, I won't get too much into the physics of it, of nuclear medicine and its imaging, the resolution is not nearly as good. And so you can't really see the ureters. The fine anatomic detail of the ureters, you can't really see the insertions, and you can't see the urethra when the patient actually voids. The grading system is 1 to 3 to compensate for the lack of resolution. In RNCs, 1 is in the ureter, 2 into the kidney, but I can't tell you blunting versus not blunting like I can with a VCUG. And then 3 is into the kidneys and a lot of tortuosity, because that I could tell you. And here are some examples. Basically, you get a picture with a big bladder full of that technetium-99m, and it's heading up there, so this is grade 2. And there's a little bit 1. Oh, it gets into the kidney, so that's 2 on the other side as well. And then this is grade 3, big, tortuous, dilated. And notice, this is the patient voiding here. I can't tell you anything about that urethra. I can't tell you if there's some fine web there or not. So that's why VCUG, basically when you're deciding, and I'm going to skip this slide because it just doesn't add anything really. When you're deciding between RNC and VCUG, I think this is a good way to do it. VCUG, first line choice for boys, because you have to see that urethra. I mean, you're doing the test, you're catheterizing the patient. Let's clear the whole GU tract. First line choice for suspected anatomic abnormality, like an ectopic ureter, like a ureterocele in the bladder, because the VCUG will allow me to see that, whereas the RNC I won't. So if you suspect something like that, let's do the VCUG. RNC, first line choice for girls, mainly because the urethra isn't as important in girls. First line choice for follow-up of reflux, because once you've done a VCUG, once you know a kid has reflux, you just want to know reflux, no reflux next year, the year after that. So why not do the study that'll tell you reflux, no reflux? You don't need to see all the fine detail again. And first line choice for screening of siblings, because there's a 30% chance, why put them through the whole big amount of radiation? Let's just know reflux, no reflux. If they have reflux, then let's consider a VCUG for further detail if there are other reasons to think about doing that. Okay, so now I'm going to just get a little bit away from urinary tract infection and let you know some other things that we can do with the GU system. So mother comes in and says, you know, I came in from out of town, I had one prenatal ultrasound, and they said the kidneys look kind of funny. I don't know what's going on. And then you call me up and say, what can I do? And I say, well, let's start with an ultrasound. There are basically multiple anatomic abnormalities. I'm just going to hit on a few of them. There are three main anomalies of form and position: duplex kidneys, horseshoe kidneys, and crossed fused ectopia. And then there's obstructed kidneys, and I'll cover those. This is a duplex kidney. 1, 2. Basically what happened is the urethral bud during embryology either split early, or maybe there was a little extra piece and it joined up, and now you have two collecting systems. This by itself is fine. 10% of you guys might have this, and probably never even knew it. And so I'll put this in my report, incidentally noted as a duplex kidney on the X, right, or on the left. Some duplex systems, reflux. This is reflux coming up and splitting into what's a bifid ureter, upper pole and lower pole, joining into a single ureter and heading down. Now, a horseshoe kidney, basically the two ureteral buds, they come together and they fuse, and they begin their ascent into their normal positions. The kidneys start low in the pelvis and rise up into the retroperitoneum, but they get caught by the SMA because they're joined, and so they can't keep going up. And that's why a horseshoe kidney normally stays right there, kind of where the SMA hooks off, or it could also get trapped on the IMA. But this is a horseshoe kidney on ultrasound, just coming across midline. This is the same thing on CT. Horseshoe kidneys, there's an increased risk of stones, increased risk of infection. Controversial as to whether there's an increased risk of Wilms tumor or other neoplasms. The last thing I heard is I don't think there's actually that. But stones, infection, and of course, you only have one kidney, so if this kid's playing football and gets hit right here by the big Maryland or NC State lineman, you want to know about the horseshoe kidney, so you can tell them not to play. You only have one kidney. Crossed fused ectopia is just a more rare, basically, you can imagine the little ureteral bud on the left decided to hook a rod onto the one on the right and rose up with the one on the right. Did not get caught in midline, so it didn't become a horseshoe, but rather became crossed fused. Here's the normal right kidney, here's the left, and this is actually an adult. No physes. But I just wanted to show you this is what can be done with a CT rendering on crossed fused ectopia. So I see this on ultrasound, and this is most likely if the parent comes into you and says, they said they had water on their kidney during the prenatal ultrasound. I don't know what's going on. Let's get that follow-up ultrasound. What happens often, let's say a kid is born and prenatal imaging showed maybe hydronephrosis, maybe what we call mild dilation of the pelvic calyceal system. Ideally, I would like to wait 1 week before doing the follow-up, the kid is born ultrasound, because there's relative dehydration right after birth. The GFR isn't up to speed. That child is not producing as much urine as the child will later, and you can get a false negative. The kid could look like they have normal kidneys, and then you bring them back in a year, and where'd this hydronephrosis come from? Well, it just wasn't there in the first few days of life. However, you have to weigh that with losing the patient to follow-up. There they are in the hospital. It was a regular birth. They're going home hopefully in 2 days. I may not see this child again. Maybe we should do the ultrasound. So if that's the case, please just give me a call. Let's have that conversation first, because ideally I'd like to wait a week to make sure to reduce the risks of false negatives. So the kidney's obstructed. Well, does it work? Well, radiology can also be used to evaluate the function within kidneys. Generally, it's a MAG3 study. That's the one that's excreted by the tubules. We'll see a lot of, I'm going to skip this. This is actually a quite boring slide. Basically, contrast comes in, it's given into the IV, taken up by the kidneys, the collecting systems start to fill, and on the right side, which is normal, it immediately starts to drain into the bladder. So you start to see bladder filling, and you don't see any buildup of contrast within the right kidney. Whereas on the left side, this contrast isn't going anywhere. This is a big dilated system, and it's just not draining. So we also get these great curves. Basically, contrast fills up. These curves are just looking at how much contrast is within the kidney shadow at any given point in time, fills up, and then starts to empty on the normal side. This one just fills and plateaus on the abnormal side. So this is delayed excretion. And then what you can do is you can give the patient some Lasix. And in this case, actually, we gave Lasix, and then a few minutes later, the kidney has emptied out. So this is somewhat obstructed, but it's not really an anatomic obstruction because Lasix can get the urine out of the kidney. And that's the major difference. This is another Lasix renogram where in the image after giving Lasix, there's still a whole lot of contrast just within the kidney. This person is definitely obstructed, anatomic obstruction, nothing's getting through that kidney. Call the urologist. Now, magnetic resonance imaging, I've touched on this. As it's a relatively new technique. As I said, if the kid's under 7, 6, sedation may be required. But the great thing about magnetic resonance imaging for kidney anomalies is that it can look at both anatomy with the clarity of a CT, essentially, and can also be used for functional assessment because there are repeated iterations of getting the signal from the kidney. So you can look at the kidney filling and draining over time, whereas with the CT, you just go through that one time. It's a one-time snapshot of the kidneys. It's, as I said, a relatively new technique. It's a very expensive way to evaluate the kidneys and function, but in some cases it may be worth it, particularly in a post-operative patient. This patient had right-sided obstruction, had a dismembered pyeloplasty. They took out the bad segment of the ureter, cut the pelvis, helped the kidney drain, try to preserve renal function, and post-op, this patient just isn't draining. Then you can look in the same plane, see it looks as obstructed, trust me, as it did before. And then also for kind of more for the surgeon, with MRI, you can do kind of just 3D rendering where you just see is the ureter showing up there? Well, trust me, there's ureter there. And they can see the insertion, they can possibly see areas of stenosis, they can see where they may have to go back in. So that's what MRI can do for you. As I said, very expensive, but there are cases where it may be the best test for the patient. So in summary, imaging can help diagnose pyelonephritis and its complications, evaluate reflux for whatever reason we may want to do that in the future, can evaluate anatomic abnormalities, and can evaluate renal function. So that's it. I ended a little bit early. And any questions whatsoever? Anything about pediatric radiology at all? I just did a focus topic, but I'll answer anything you want to know. Yes?
A lot of kids come in, mom says, fell down, bumped his head, fell off the countertop or whatever it may be. Question for the imaging of the head.
Yeah.
The kind of bleed that tracks the skull, whatever it may be. What are the current recommendations for imaging the skull after a child fall on the head?
Oh, wow. Well, I'm embarrassed to say I don't know that one. I'm going to have to check the ACR appropriateness criteria. I'm sure it has to do with the height of the fall. Of course, let's back up. Any symptoms? Symptoms image. Kids acting fine, bump their head, little suspicion. It's kind of on your side, I think. That's unfortunate. I do have to bounce it back to you. If you're worried about something, we'll take a look. But in terms, what is it, 2 times, 3 times? It's some X times the kid's height, I think is the fall. And then, of course, mechanism of injury, sharp object. Do you feel a big dent?
Do you X-ray or CT?
I can defer to Dr. Douglas for that one. I would think I would CT pretty much because you're thinking, okay, if the kid had enough force and you're worried about a skull fracture, then you're worried about bleeding in the brain. And the CT is going to show that. The X-ray won't. The X-ray is going to show if there's a step off. Exactly. X-ray is great for craniosynostosis, seeing if the sutures are open, seeing if there's bulging, looking for bony lesions. But if you're worried about something inside the head, CT it. Sorry, yes?
On the children with the anatomic abnormalities, like the horseshoe kidney, do they have, like, what are the problems that they have? Like, is it normal function? Or?
Usually it can be quite normal function. They will also get MAG3s, DMSAs to test for function. But their major problem is, if you imagine, okay, so the kidney's being formed, and sorry, I've been told to repeat the question. What are the problems with a horseshoe kidney? The kidney's being formed, and normally it comes up and it rotates, so everything's the way it was intended to be, drainage and everything. With a horseshoe kidney, it's malrotated as well. So the ureters are coming off at funny angles and heading to the bladder. That can increase the chance of urinary stasis. More urine stays in the pelvis instead of draining. That can increase the chance of stones. That's what increases the chance of infection. Now, the thought was that you have an increased chance of infection, you have an increased chance of stones. That increases overall inflammation. Inflammation makes genes go bad. Genes cause cancer. That's why they thought they may have higher risk of Wilms tumor and other neoplasms. But I think it's kind of bearing out to be not the case. So the major risks of a horseshoe kidney are increased infection, increased stones, and the risk of trauma. Because it's right there against the spine, you get a blow to the abdomen, it's going to break the kidney across the spine. Whereas if you have a kidney on each side and you get a blow to the abdomen, one, you have two different kidneys, the odds of knocking both of them out with the same blow is less. And two, because they're protected by the liver, sorted by the spleens and the ribs, they're more protected than if they're just hanging out in the midline. Does that make sense? I would say yes. Yeah, I would have the same recommendations. I mean, it's a discussion you have to have with the parents, but basically they are at higher. Would I let my son play football if he had a horseshoe kidney? Probably not. It's a hard decision, right? Because, I mean, let the kid grow up. But may gear them towards less contact sports. But that is a discussion you can have with the parents. Where I'm not going to tell you, I'm not going to put in my report, don't let this kid play. I mean, that's a risk-benefit analysis that you as the primary caregiver would have to have with those parents. I think there was a question in the corner first, actually.
Yeah, I just had a couple questions about the magnetic resonance urogram.
Okay.
Is that available everywhere or only at major medical centers? And what are the chances that the insurance will pay on it? Isn't it very expensive?
Oh, it is. So the question was magnetic resonance urogram, what's its availability, and will insurance pay for it? I don't know the answer to the second question, and I'm sure that's going to constantly be in flux with the insurance companies. In terms of its availability, well, the first thing you need is an MRI. So if you have access to a medical center with an MRI, there's a good chance you can get one. Then you need MR technologists and radiologists who can perform the exam. You need the radiologist to basically tell the technologist what sequences to perform, which planes, and how to do the post-processing. And then you need a technologist who can actually execute that plan at the scanner. So again, if that's something that you thought you had a patient needed, I would definitely call the radiologist at that institution that you were thinking of sending the child to, and just have that discussion. Say, okay, I know this is, and yes, it's very expensive. And say, yes, I know this is not usually what's done, but this kid has X. I think this is a good test for them because of Y. And then we'll have that discussion, and hopefully the radiologist, I know I'll always be honest with you if we just can't fit them in, or if there's just not enough expertise, either radiologist, technologist, or equipment-wise on any given day, we might not be able to do it. But otherwise, yeah, we'll just say, yeah, we can do that. Yes, sir.
Imaging in the setting of possible appendicitis.
Ah, my favorite topic.
Pardon?
My favorite topic, but go ask your question.
Yes, two, it's probably multidimensional. One is age, the modality for age, and then I guess also severity, probably from different dimensions, or increased or pretest probability.
Yes.
So
How do you do all that? All right, so the question was regarding imaging and appendicitis. And ideally, your radiologists, and I'm going to talk about the ER because that's what we did at Children's Hospital Boston. Your radiologists, your surgeons, and your ER physicians will sit down and look at your population, look at what you've done in the past, and look at what has worked. In general, with a female patient, this is what we ended up doing at Children's. ER physician saw the patient, high suspicion for appendicitis. Remember, it's also a clinical diagnosis. They could go straight to surgery. At any point, that could trump everything and they just go to surgery. If there are good signs and symptoms, and if the BMI is low enough, and if it's a girl or if it's a boy with a low enough BMI, we would go to ultrasound first. kind of no matter what. And the reason we would almost always go to ultrasound with girls is twofold. One, the increased sensitivity of the ovaries to the radiation. It's right there in that field that we'd be doing the CT. They're right at the level of the appendix. And two, because there is so much ovarian pathology in females that mimics appendicitis, particularly torsion. So we would say, well, let's do the ultrasound. If you have normal ovaries, no free fluid, no inflammation, this kid just has belly pain, maybe consider just sending them home. Because by that time, the labs have also come back. Maybe their pain has gone away, maybe their fever is broken. With boys, at least myself, and we're always willing to take a shot. 5 years old, 7 years old, not too big, not literally big, because fat, intra-abdominal fat, takes away all of the sound waves. It bounces them right back at you, and you can't see that far with an ultrasound. Give it a shot. Let's look for the appendix. Let's try and save them the radiation. Now, if the ultrasound is suspicious, but not a diagnostic, then let's go to CT. Let's end the discussion there. If the ultrasound is negative and your clinical pretest probability is low, let's end this. If the ultrasound is positive, go to surgery. Then in terms of the length of time of the symptoms, so if the surgeon comes in and says, okay, this kid has had right lower quadrant pain for 7 days, they stayed an extra 2 days at the beach after that, and I think this is perf appendicitis. I think there's abscess all over this kid's abdomen because he's tender, guarding everywhere. Why don't we go to CT? Because ultrasound will make that diagnosis, it'll show you the fluid, but if you need to know where those abscesses are, so you can do drainage beforehand, want to make sure there's nothing else, no other surprises in there, let's do the CT in that case. So yeah, a lot of pediatric radiology is moving targets. You know, what I would like to do, I have not done it yet, is at least talk to the surgeons and the ER physicians in our community and try to come up with a plan, you know, just kind of see. So at least so you can have some consistency. But then again, always a good answer is to talk to your radiologist, because some radiologists aren't comfortable reading ultrasounds for an appendix. And they're going to say, non-specific study, let's go to CT anyway. And why would you spend that time? Why stop preventing, you know, either dispo or treatment? So talk to your radiologist. Say, I have this child down in the ER. Here are the symptoms. What do you think? And most of the time, at least if I'm on the phone, I'm going to try the ultrasound. But we can have that discussion too. If you think it's a really good case, you just need to know so they can go to the OR, I'll go to CT. Yes, sir.
Somewhere along the line, I remember hearing or reading that the radionuclide cystogram is more sensitive than the VCUG. Is that true? Or?
Yes, and that's because of the intermittent nature of reflux. Basically, the VCUG, when you hit the fluoropedal, you give the x-rays, and you might see the reflux if it's happening there. And it's a quick test, and I'm looking pretty frequently. So there's a good chance I'll see it. Whereas the radionuclide cystogram is over the entire length of the exam, which could be 20 minutes, could be 30 minutes of filling, voiding, refilling, voiding again. It's just constantly imaging. And so there's that chance. I think it's a little bit higher sensitivity for intermittent reflux. Anything else? Yes, ma'am.
We see a lot of kids that come in for VCUGs into a UTI. How many UTIs do children usually have prior to being recommended for VCUG?
All depends on so how many UTIs do kids normally have before being recommended for VCUG was the question. And it just depends on who is ordering them, pretty much. As I said, the recommendations are a moving target. AAP, I think at some point said that all kids with UTI, there are some urologists, I think, who believe any febrile UTI in a boy or a second febrile UTI in a girl. That's just what we were, kind of the mantra at Children's Hospital Boston is what we used, but I know it's different. And we would get children sent to us with just UTI, no fever, and some of my professors would say, well, this test isn't technically indicated. And some of my professors would say, well, we should do the test because they obviously know a lot more of the story than they're telling us on the piece of paper. Maybe we can't get a hold of them on the phone, can't talk about the history some more. And so I'll always have that discussion. But I think, as I said, if you send a child for VCUG to rule out reflux and you think it's an indicated study, I'll do the study. One case, we just had a strange situation, kind of when I first started, where the child had a distant family history of anaphylactic allergy to contrast. So the parent was very worried about getting the VCUG, which uses the IV, which uses the contrast. Not in the IV, we only put it in the bladder. But still, you hear the word contrast and it's your kid, you're worrying. So in that case, I sent them to RNC instead. That was a case where maybe we didn't need to do, first of all, let me say there's almost zero risk because it's not going into the veins of a contrast reaction happening during a VCUG, knock on wood. But that's just one of the good reasons. It's good to have options. Because if you have a very worried parent, why put them through more stress? If it was a girl, RNC would give me just as much information, the reflux, no reflux. So we just sent them to RNC instead of VCUG. So I think I avoided your question sufficiently. Yes, sir.
The chart that you handed out mentioned sedation for MRI, and it doesn't mention for anything else. How often do you use sedation for younger children for CT and ultrasound?
I personally have never sedated a child for VCUG or RNC.
How about ultrasound and CT?
Never ultrasound. CT, it's depended on what we're looking at. Head CT, the kid can mostly stay still. Short segment, you have a very fast scanner, you might be able to get through it. Let's say you're doing a CTA for some tumorous lesion, cancer, and you need to look at the vessels, and you don't want to scan the kid. It's 250 times radiation of X-ray. You don't want to run through them again. In that case, I'd sedate them. Or if for some reason you're worried about lung disease, lung nodules, you're following up something, then I would sedate just to make sure you do it once, do it right. Otherwise, try pretty much not to. CT scanners are pretty fast. Most of the things we image are pretty small, and you could do it. And then, as I said, I haven't done it with VCUGs, RNCs, an ultrasound. They move around a lot, but I can move around a lot too. So, do our best.